This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, host of the show. When COVID-19 first appeared more than a year ago, it was thought to be a disease of the respiratory system. But we know now that COVID-19 can be a multi-system disease, impacting many organs and the entire nervous system. Dr. Igor Koralnik has been investigating the neurologic symptoms of the disease and has published the first study focused on long-term neurological symptoms in COVID-19 long haulers. Long haulers in this study refers to people with confirmed symptoms of COVID-19 who were never hospitalized yet have neurologic symptoms lasting more than 6 weeks. Dr. Koralnik is the chief of neuroinfectious disease and global neurology in the Ken and Ruth Davey Department of Neurology at Feinberg and oversees the Neuro COVID-19 Clinic at Northwestern Memorial Hospital. Thank you for joining me today.
Hello, Erin. Thank you for inviting me. I'm delighted to be distancing socially with you and with all your listeners today.
Early on in the pandemic, you, like everyone else, thought COVID-19 was a respiratory disease. When did you realize that there was a neurological component?
This is a very good question, and we were made aware of this fact by reading the first report that came out of Wuhan, China, where they had seen the first hospitalized patient with COVID-19. And it was a paper published in JAMA Neurology, I think in March or April 2020, that already told us that about 30 to 40% of hospitalized patients with COVID-19 had some neurologic manifestation. Those were sick patients, hospitalized with pneumonia, many of them intubated in the ICU, and they had a range of neurologic symptoms and manifestation that really started our work here at Northwestern.
How many COVID patients report neurological symptoms?
The hospitalized patients with COVID-19 who have severe pneumonia may have a range of neurologic symptoms. And the most severe is encephalopathy, which basically means dysfunction of the brain functions globally that goes from mild confusion to coma. In addition, patients can also have headache, muscle pain, dizziness, disorder in smell and taste, and a range of peripheral nerve dysfunction, including Guillain-Barré syndrome. In addition, severely sick patients may also have stroke and seizures.
There's a term called brain fog that we've been hearing a lot about, that it's also been reported with some of these folks either who have been hospitalized or not. Can you tell me what exactly is brain fog and how can it impact otherwise healthy people?
So now we're talking about in other category of patients who have not been hospitalized with COVID-19, and they are the so-called COVID-19 long haulers, a term that has been chosen by the patient themselves to, by analogy to the long haul drivers who carry very heavy load over a long period of time. And brain fog is a term that describes their difficulties with attention, memory, multitasking abilities to work at their job in their usual capacity.
Tell me, when did you start seeing COVID-19 patients with these sort of neurological symptoms like brain fog, and what led to establishing the Neuro COVID-19 Clinic at Northwestern Memorial Hospital?
The first foray into this came out from one of our first-year med students, Mr. Jeff Clark, who is part of the podcast today, who contacted me March or April 2020 because he was interested in doing a summer project on the topic of infectious disease. And we discussed, what could be interesting. There was this new pandemic. We knew that the neurologic system was going to be involved. We decided then to do a retrospective analysis of the first 509 actually COVID-19 patients who are hospitalized at Northwestern Medicine. At the same time, I had already met two neurocritical care attending, Dr. Ayush Batra and Dr. Eric Leota, who were actually seeing those patients in the ICU, because that was going to be a very big undertaking. Jeff brought two of his fellow first-year med students who are Nathan Schlobin and Stephen Hoffman. All together, we formed our first Neuro COVID research working group. And together, we analyzed the first 500 patients who were hospitalized at Northwestern Medicine. And we found out in total, 82.3% of those patients had some neurologic manifestation, which was even more than what we saw coming from Europe and from China ahead of time. One of the reasons is that our patients were not as severely sick as the one that were in China or in Europe, and only a quarter of those needed to have mechanical ventilation in the ICU. And so basically, doctors who took care of them had the opportunity to ask them all the different questions, about their symptoms. So the most common symptoms of neurologic manifestations in hospitalized COVID-19 patients were muscle pain, headache, encephalopathy, dizziness, trouble in smell, and trouble in taste. But in addition, some also had stroke and seizures and other peripheral nervous system problems.
You sort of hosted what you called a Neuro COVID summer camp for the medical students and the team that you assembled to do this research. I would like to hear a little bit about that and just sort of what that experience was like to bring these different medical students together along with fellow scientists to dive in to better understand these patients.
The students wanted to do a chart review or some summer project. They got much more than they bargained for, really, because they had to appraise the current literature. And there was a lot of papers coming out, little case series or case report mainly about various neurologic manifestations in those patients. We had to pull all the data from the EDW, get the records from those patients to analyze. And then the students spend the entire summer poring over those records, putting them in an organized fashion so we could study the percentage and also risk factor for all those manifestations, and finally analyze the results and publish this paper in October 2020.
I actually had a chance to talk to one of those medical students and a fellow who has worked on these papers. Here's what they have to say.
My name is Jeff Clark, and I'm a rising third-year medical student at Feinberg. I definitely think that on the whole, this has been a really influential experience. Just having access to mentors like Dr. Koralnik, Dr. Graham, Dr. Leota, Dr. Batra, everyone involved has really given me exposure that I would not have otherwise had this early in medical school to what the aspects of clinical neurology, virology, and the intersection of neurology and infectious disease look like. And it's definitely very interesting. And like I said, something that I wouldn't have necessarily gotten exposure to.
I'm Dr. Edie Graham, and I am the Neuroimmunology Fellow at Northwestern Medicine. I've been working in the clinic weekly with Dr. Koralnik. I think I was surprised initially by the fact that the patients we were seeing a lot of them were otherwise healthy. Yet after they had mild COVID, they were continuing to have these neurologic symptoms. Initially, we thought this was looking like some other syndromes that we've seen before, like post-concussive syndromes. Later, we were realizing that there's really quite a heterogeneous population of patients that present to our Neuro COVID-19 clinic. So they really don't all have the same symptoms. So it was interesting to see the different manifestations that people are having.
So there's that project where you're pouring through the medical records, looking at these hospitalized patients, but then you have your clinic over here, your Neuro COVID-19 Clinic, where people are starting to come in. You said starting in May, doing through telehealth, now in person, to the tune of about 60 people a month. Now, tell me how you started to study those folks and what you hoped to understand by studying them.
Because we understood that neurology was going to be such a big problem in COVID-19 patients, and because the hospitalized patient would need to have a place so that they could be followed up after the discharge, and also because we started hearing about those non-hospitalized patients who had problems, we opened the clinic during the lockdown in May 2020, which was one of the first Neuro COVID clinic in the US. We wanted to give full access to as many patients as possible. So everybody could come in televisit from the entire United States between May and July 1st. And after July 1st, a mix of in-person and televisits. We did not require physician referral for patients to be able to come in the clinic. And also, we did not require to have a positive SARS-CoV-2, either a nasal swab or serology. And so why did we make this conscious decision? Because if you remember, at the beginning of the lockdown, it was very difficult to get tested anyway if you did not have pneumonia or at least severe disease by nasal swab. So many patients could not be tested. If they got tested after that, they were not having respiratory symptoms anymore. So their sore throat, cough, and mild headache had gone away. They were not shedding the virus, so they would test negative with the nasal swab. In addition, the first serologic test for SARS-CoV-2 antibody was produced during the lockdown by a company called Abbott, and they did a very good job getting this test out commercially, but it was a test that looked for antibodies against one protein of the virus called the nucleocapsid protein. And it turned out that it was not as the most sensitive test. And it was also calibrated with a sample from severely sick patients who were hospitalized with pneumonia. It was not calibrated to detect antibodies in people with mild infection. And we know now, compared to the newer tests that look for antibodies against the spike protein, for example, that the initial test was only 80% sensitive. In addition, other researchers have found that the level of antibody against SARS-CoV-2 decay quickly in the blood. And so you may have antibodies one day, but then it goes down over time. And it may go down below the level of the detection of even the most sensitive assay. That means that you have long haulers who have the exact same neurologic manifestation as those who test laboratory positive for the virus, but they test persistently laboratory negative for the virus. And since about 50% of the population of the clinic was laboratory negative, we also included these people in the first study that we published of the first 100 long haulers in the clinic, and that was published last week.
Tell me, how did you evaluate or examine these patients then? How are you able to help patients in this clinic, and what do you prescribe?
Half of the patient came in televisit, and half of the patient came in person. And a clinic visit is always an hour-long visit where we take a complete history of the patient's symptom, past medical history, medication, and we do a complete neurological exam in person, and we do a more limited neurologic exam when it's a televisit. And what we found out was very interesting is that among the non-hospitalized long haulers, that means people who are never developed pneumonia or low oxygen level in the blood, who only had transient respiratory symptom that went away and after developed their neurologic problem, the average age was 43, which is about 10 years younger than those who are hospitalized, and 70% were female. So, of course, it is a self-selected population of patients who came to see us in the first place because they had neurologic problem, but we had the widest possible access, and it turns out that 70% of patients were female. 85% reported at least 4 neurologic symptoms, and the most frequent neurologic symptoms in the long haulers were brain fog, headache, numbness and tingling, disorder of taste, disorder of smell, muscle pain, dizziness, pain, blurred vision, and ringing in the ears or tinnitus. And these symptoms did not come alone, unfortunately. They were interspersed with other type of symptoms, either respiratory symptoms, shortness of breath, or chest pain, despite the fact that those patients never had pneumonia, variation of heart rate and blood pressure, and as well as gastrointestinal symptoms, nausea and diarrhea, together with intense fatigue.
You mentioned, women in their early 40s. I'm actually a woman in my early 40s. So this is pretty concerning. Is there a reason why like you said, it's self-selected people who are coming into the clinic, but have you been able to pinpoint any other reason why these younger women in their early 40s seem to be affected?
It is a very excellent question. And other COVID clinics in the country have seen the same thing. What we also saw when we ask patients about their comorbidities, that is, what kind of disease they had before COVID, 16% of patients said that they had some other autoimmune problem before COVID. And that fits the hypothesis that long COVID is not a persistent infection of the brain, the meninges, or the nerves by the virus, but rather a post-infectious autoimmune phenomenon where the virus has gone away, but confused the immune system to think that something is foreign in the brain and needs to be attacked. And we know that women are more likely than men to develop other autoimmune diseases, such as multiple sclerosis, rheumatoid arthritis, or CNS lupus, for example.
And all of this is detailed again in that recently published article in the Annals of Clinical and Translational Neurology. What has reaction been to this paper that you just put out?
This is the first of its kind study talking about neurologic manifestation in non-hospitalized long haulers. So it generates a lot of attention. And as you know, people are very organized nowadays. And so you have hundreds of thousands of those long haulers who already congregate on Facebook or Slack groups or, Survivor Corps websites. And, they're organized and they're also putting out their own publication on the topic. And I think it's really good.
Do you think there's going to be a continued need for the Neuro COVID-19 Clinic in the months and years to come?
We have seen that not only patients have symptoms, but they have decreased quality of life. And we ask them a standardized question. It's called patient-reported outcome measure or PROMIS measure related to their cognition and fatigue, and compared to a large normative population demographically matched in the US, those patients have worse quality of life. In addition, we also do standardized tests for their cognition using the National Institute of Health Toolbox, or NIH Toolbox, which is a tablet-based test that takes 20 minutes to perform at the end of the office visit. And we test for their processing speed, their attention, their executive function, and working memory. And we see that some patients who are highly functioning individuals, who are, teachers, nurses, business people, physicians, and so on, test below average compared to their normative population in the US as well, especially in measures of attention and memory. And those people who, are used to multitask all the time, either taking care of patients in the ER or, taking care of a large workforce in the industry, have difficulties and struggling to do their daily activities. And about half of the population of the study missed at least 10 days of work. So this is going to have a persistent impact on the workforce. Now, the light at the end of the tunnel is that we're understanding better what is happening with them. And we're also starting to do cognitive rehab for some of those patients, and with good results so far.
This isn't the first pandemic that you've been involved with. During the HIV/AIDS pandemic, you were also studying that virus, and there were also neurological symptoms with that virus. How did your background in HIV/AIDS prepare you for this current pandemic?
Well, you did your homework, Erin, and this is true that I started out back in the 90s as an HIV neurologist. I was interested early on when I was a med student back in Switzerland about this new epidemic, or that became a pandemic, HIV, and that was soon thereafter found to also affect the nervous system in many different ways. But HIV caused immunosuppression, and associated with immunosuppression come infectious disease. And so this is a totally different syndrome than we have with the COVID-19. Also, HIV affect only selected people, and now COVID-19 can affect everybody, basically. But 25 years of experience studying how HIV and other viruses affect the nervous system obviously taught me a lot on how to approach and handle the neurologic manifestation of COVID-19. And since I'm a physician scientist, we're also studying this in the lab. And as you know, there are different arms in the immune system. The B lymphocytes are producing antibodies that you can detect with the serological blood test. But we're studying the T lymphocytes, which are the part of the cellular immune response against the virus, more like the SWAT team that goes door to door or cell to cell to find cells that are infected with the virus and destroy them. And those T lymphocytes have memory, and you can interrogate this memory. So the cell can tell you, yes, I've been exposed to the virus, or no, I have not been exposed to the virus. And we already see that some of the laboratory negative long haulers who test negative with the blood test and negative with the nasal swab actually have T cells that have a pattern or a signature that is similar to those that are laboratory positive. We have also some patients who look more like healthy controls. So we're trying to tease out what is happening in this population. And we also think that there's something dysregulated in the T cell response against COVID-19 that caused the brain fog, trouble smell and taste, and headache, and so on in this patient population.
You mentioned that some patients are undergoing rehabilitation. What is happening right now with recovery for the folks that you're seeing in your clinic?
Excellent question again. And we were hoping that with time, patients would improve. And we are asking question to all of our patients, what % recovered do you feel you are today compared to your pre-COVID baseline? And so if patients say 100%, that means they're back to baseline. And we were hoping that patients only, let's say after 1 month from disease onset would say, I'm only 10% recovered, but after 9 months, they would say, I'm 90% recovered. Unfortunately, that was not the case. And in average, patient came to see us for the first 100 patients that we reported in this study, about 5 months from their symptom onset. And they said at that time that in average, they were only 64% recovered. But some patients recover mostly after 2 months, and some patients after 9 months are only 10% recovered. So we can't give you an estimate if you come to the clinic, when your symptom will be over. This will be dependent on the individual. And it's also not an homogeneous population. Some people have only transient disorder, smell and taste, and then persistent headache, dizziness, and brain fog. And some people never have brain fog or dizziness, headache, but they have 9 months out persistent disorder of smell and taste. So everything that they smell smells like rancid fish, and everything that they taste like metal. And so they are impacted in a completely different way.
So will we be seeing more papers over the coming months as you find out more about these patients in clinic?
We want to know how long is long COVID. So we're following those patients over time, 6 to 9 months after their initial visit, to see what improved, what didn't improve, to test also other type of interventions, because we can take care of headache, we can take care of fatigue with mild stimulant, we can take care of dizziness, we can take care of pain, and we can also continue to follow those symptoms over time and send patients for different type of rehab. I think it's very important for people to be vaccinated. As you know, in this country, there are a number of societal factors that may prevent or slow down the rate of vaccinations in this country. We've seen patients who were naturally infected and get reinfected after that. We hope that vaccines are going to prevent reinfection, or at least, worst outcome after infection. And long haulers or even people who are hospitalized with pneumonia should get vaccinated as it is available to them in their geographic area. There have been reports in the news that you may have heard of that people with the long haul COVID got cured from their symptom of the vaccine. We have seen more than 400 people in the COVID-19 clinic so far, and this is not what we've observed, although this is a younger demographic, so few patients got the vaccine yet, but we see sometimes a transient worsening or relapse of the long COVID symptoms that went away, and it is very important for patients to be vaccinated as soon as they can.
Excellent. Well, thank you so much for all this information and the work that you're doing. And hopefully this long haul COVID with more vaccines coming online won't be such a problem in years to come.
Well, thank you very much, Erin. And this is an evolving situation, obviously. There are also viral variants that are emerging in many different locations in the world. And so this is going to be a race between vaccination strategies that hopefully will bring herd immunity and the virus that wants to mutate away from the protection that is conferred by the vaccine. And so we need to be vigilant and continue to listen to the guidelines of the CDC on this matter.
Thanks so much for listening to the show. You can always head to our website, feinberg.northwestern.edu, to listen to past episodes of the show, claim CME credit, and subscribe. Subscribe on Apple Podcasts or wherever you download your shows so you never miss an episode. Thanks for listening.